I'll do a bit of physics as usual and then move to the clinical aspects and also how to deal with some emergencies related to this. So we'll start with the physics part of things as usual. Okay, so laser is a fairly new practice in medicine, but it was first described by Albert Einstein in 1917, but it was never in use at the time. And then Theodore Mamain then in 1960 brought it into practice, and then ever since then there's been evolving technology and use of it. So laser, as we all know, that it stands for light amplification by stimulated emission of radiation. That's what laser stands for. They usually ask this for some reason. So laser, I can say it's light, but what makes it special? Why is it so different from the other light that we usually see in our everyday life? Well, it's because it's monochromatic, which means that it has only one wavelength. It's coherent. This means that all the photons are in phase, just like marching soldiers, not our soldiers in South Africa or the SAPS, unfortunately. And then it's directional. It means that the photons travel parallel to each other, and then it's collimated, and then meaning that the photons are aligned. So it's also very high energy light. That's why we use it for surgery as compared to the light that we are used to. So this then makes sense why laser only has one color, because of these one color and also very high energy because of these features. So this is just to emphasize the characteristics of the laser. As we said, it's monochromatic, directional, coherent, and then these properties we've just discussed makes laser light focus 100 times better than the ordinary light. That's why it's high precision, and it's also used for high precision surgery. So where do we use laser in our practice? So it can be used in ophthalmology for anything that can be excised using laser, because it's a small organ and they might be working in small spaces and they need precision not to damage the adjacent structures. It can be used in dermatology. It is used in ENT. In our case, most of the time, it's used in ENT in our setting. It can be used in gynecology, in general surgery, urology, vascular, and then neurosurgery, dentistry, thoracic surgery, and then also orthopedics. So now let's talk about the components of the laser itself, the machine that produces laser. What are its components? So it has three components: a gain or lasing medium. This medium could be a solid, liquid, or a gas. So as I'm saying, this lasing medium could be a liquid, gas, or a solid. We'll talk about that later. And then the energy source, it could be a high voltage discharge, it could be a chemical reaction, it could be a diode. We spoke about diodes when we're doing pulse oximeters. It could be a flash lamp, or it could still be another laser that's already working. And then now there's an optic resonator or optic cavity. So this cavity contains this lasing medium, and it has two parallel mirrors on each side, and then one mirror is fully reflective and the other one is partially reflective. You will get to understand why you have to have these two different mirrors parallel to each other. Okay, and then as we know that we get to comprehend better with pictures, so there'll be a lot of pictures. It's just to emphasize what we've already spoke about, that we'll have a lasing medium, which is this. We said it could be made up of a solid, gas, or a liquid. And then we also have a source of energy, as we said that it could be different sources like electrical, chemical, or even another laser. And then mirrors, which are this side and this side. This one is fully reflective. This one is partially reflective. Yeah, this one is partially reflective, and then this one is fully reflective, and then this is the energy source. Yeah. Okay, now before we even talk about now the nitty-gritties of laser, we need to understand our high school physics. We need to understand an atom. What is an atom? We know that an atom is defined as a basic unit of matter. So if we were to magnify this basic unit of matter we can see, which is atoms, you would see something like this. So an atom is comprised of a center that is called a nucleus, and inside it has protons. And then around in different orbits, there are electrons around this nucleus. So that's what makes up an atom. So it's a nucleus with electrons orbiting around that nucleus. It will make much more sense why it's like that. So now, what happens at an atomic level when it comes to laser, or generally? So when you apply a source of energy to an atom, and then these electrons will be excited from a state. The electrons around the nucleus, it will be excited. So it means that it will move from a state of low energy, which is ground state, to a state of high energy, which is called an excited state. And then now, once it's at that level, obviously it has to go back. So when these electrons return now from a state of excited state or high energy to a state of low energy, there is a release of energy, and this energy is released in the form of photons. We know that photons are a basic unit of light. So when that happens, when the electrons move from an excited state to ground state, there's a release of photons, which is a form of energy. And then now the wavelength of these photons, they depend on the difference in the two energy states, which is the excited state and the ground state. So it means that whenever this happens, you won't get a wavelength that is outside these two states. So it's a wavelength that is exactly like these two states. And this whole process is called spontaneous emission of energy. Okay, if you have any question, you can note down, and then maybe we can discuss at the end. And then now, so this is just to still show how a laser is made. So it's still the power source, and then now remember the what I've just explained happens at this level. When you apply a source of energy, the atoms will be excited and also release energy within this, and then there'll be more electrons will be moving around here, and also including photons. So now, okay, I'll skip this slide. It's still the same thing. Okay, so now after this spontaneous stimulation now from external source of energy, now with continued source of energy, and also now remember there are already produced photons from electrons moving from a region of high energy to a region of low energy. They emit energy in the form of photons. These photons will then interact with other atoms that are already excited, and they further activate them. So when energy now is applied to these atoms, and then the electrons on those newly excited atoms will jump now from a region of low energy to a region of high energy. And then now, when also those electrons return to a ground state, they emit further photons. And then when this happens now, there are more and more collisions. There are more and more collisions. Then as a result, when that happens, when each photon reacts with an atom, two more photons are released. And then they are usually identical in direction, polarization, and also the wavelength. They can't have a wavelength that's outside the energy states. So as I said, remember that these photons will be in the same phase, in the same direction, and also have the same wavelength. I hope you understand that it's just a closed, if I may put it that way, it's a closed system that electrons get excited, they go to an excited state. Once they're in the excited state, when they return to a ground state, they emit energy in the form of photons, and then these photons with continuous source of energy will further activate other atoms, and then when that happens, two more photons will be released from those atoms when they return to a ground state. Okay, that was stimulated emission. And then now there's population inversion that I'm sure you came across when you were reading. This one it just simply means that the number of excited atoms exceeds those that are in ground state. And this can only be achievable by continuous input of an energy pump or energy source. And this is what maintains laser activity. And now you will wonder, how does then this laser light leave this medium? Don't worry, we will get to that. Just to emphasize what I've already mentioned, that with stimulated, there's spontaneous and stimulated emission, and then there's population inversion from what we've discussed. So an electron will be in the resting state, yeah? And then now, which is ground state, low energy state. And then now there'll be a source of energy. So this electron now will move from this low energy state, which is the ground state, to a high energy state, which is excited state, with the aid of energy. And then now what will happen first is spontaneous emission. How does that happen? We already mentioned that. Once electrons move to a high energy state, when they return back to the ground state, they emit a single photon they emit energy in the form of photons. But now with continued energy source, this photon that is emitted here will further activate other atoms. And when that happens, that atom will emit two more photons. That is our stimulated emission. And then population inversion simply means that now there'll be more electrons in the active state as compared to electrons in the in the ground state. And then this is only sustainable when there's a continuous source of energy. So which laser light is usable? Remember, we said this happens in that lasing medium. We haven't spoke about what leaves that medium and how it leaves that medium. So some photons are allowed to leave the medium through the partially reflective mirror. If you remember, I mentioned that there are two mirrors on each side. There's one that is fully reflective, and then the other one is partially reflective. But they also need a delivery system. So this is what I was. So here there'll be spontaneous. Here there'll be spontaneous emission, then stimulated emission, and then there'll be population inversion. This is fully reflective, so it will not allow anything to go through. So it will reflect towards this direction, and then this one is partially reflective, and it will have a slit here to allow some photons to leave. So when they leave these photons, remember we said that they'll have the same wavelength, same direction, same energy. Okay. So now here, these electrons that are here, or atoms, they are in the ground state. And then this side, it's a partially reflective mirror. This side, it's a highly reflective mirror or fully reflective mirror. You apply energy, some electrons, they become activated, so that those are the red ones. They become activated, and then when they return to the state of low energy, they'll emit photons. That's your stimulated emission. And then population inversion simply means that there are more activated atoms or electrons as compared to the ones that are in the low ground state with a continuous source of energy. So, and then when that happens now, this mirror will reflect, will not allow anything to go through, but everything will go towards this direction. Because this one is partially reflective, some of these photons will go through, and this is what we use for surgery or for whatever as laser. It's what leaves this side. And this needs a special delivery system. So just to show you that we already spoke about the electromagnetic spectrum in the previous presentations, like our pulse oximeters and all. The reason that we can see laser, it's because it lies within our visible spectrum, which is, it's usually ultraviolet or infrared light. Yeah, so the wavelength is around here for laser. So now, what are the examples of laser? It could be carbon dioxide laser, which is used for cutting and coagulation of soft tissue, or it could be holmium, which is also called YAG. It's for tissue ablation or lithotripsy. That would be for mostly in urology. There's an eczema, which is also called argon or fluorine. It's for corneal reshaping. These are according to the different wavelength, whether it's short or long wavelength. For example, this one, it's short wavelength because you don't want to penetrate the eye too much, because you might cause damage to the adjacent structure. So this all depends to the wavelength. So now, before we even use this laser, what should we know about it? Unfortunately, surgeons will never know about these things. We are the ones who have to know about things that we don't even use. So before we even use this laser, for adequate medical exposure, there are some things that you will need to meet or we need to be aware of. There's what is called irradiance or power density, which is essentially just laser power per unit area. So yeah, that's called irradiance. And then fluence or energy density, it's this irradiance multiplied by the exposure time, and it's measured in joules per square centimeters. And this is the measure of the total energy of the laser. And then now, also we need to know that with prolonged exposure, there's more tissue destruction. With a very short exposure, there could be inadequate effect. You might not be able to achieve the desirable effects. So just keep in mind the irradiance, or which is also called power density. It's laser power per unit area, and then fluence, its irradiance, is this multiplied by the exposure time. So why is this laser advantageous? It's because it's precise. It has ability to focus the laser beam. There's limited blood loss, minimal damage to adjacent structures. There's less scarring and also less post-op pain. So as much as it might be dangerous for the patient, but it's also very beneficial for them because of these things. And then now, before we even now apply the laser on the patient, we need to anticipate what will happen when we apply the laser. So a living tissue is light absorbing. We all know that even from the pulse oximeter talk, we heard that a hemoglobin absorbs light. So when an atom interacts with a photon, it vibrates and then it produces heat. And then now, when this, for the clinical effect to occur, the tissues need to absorb the laser light, nothing else. But now, what determines this absorption? It's the wavelength that we already spoke about. The power density, we already spoke about. The duration of laser, we already spoke about. How much is scattered, because if it's scattered, it won't have a biological effect. The thermal conductivity of that tissue, the blood circulation around that area, and also now, the longer the wavelength, the more it's absorbed. For example, carbon dioxide laser has a longer wavelength, and it's highly absorbed there's more penetration into the tissues. This is just to show the different wavelengths and different lasers at those wavelengths. And you can see that the one that has a longer wavelength or taller wavelength is CO2. And remember, we spoke about argon not so long ago. It has a shorter wavelength because you don't need to penetrate a lot when you're doing, for example, eye surgery. Okay, so this is just to emphasize that the longer the wavelength, the more the penetration. The shorter the wavelength, the lesser the penetration. So now let's say you apply the laser to the patient or to a tissue. So 4 things might happen. It would be transmitted, it might be scattered, it might be reflected. All these 3 don't have a biological effect. What you need when you're applying laser, you need it to be absorbed by the tissue so that you get the desired biological effect. So just to share that, we know that most of our body is made out of water. So water absorbs more infrared, hemoglobin absorbs more visible light, and then melanin absorbs both visible and ultraviolet light. And then now let's say you've applied the laser on the patient. but now you need different modes, just like when you're using a diathermy. So there are 3 different modes for laser. There's a continuous, pulsed, and also Q switching. The continuous one is just continuous flow of energy. It's not intermittent. This might cause more damage. Or yeah, and then number 2, the pulsed one. This one is multiple discrete pulses, so it's intermittent. Then the Q switching is just the combination of the 2, and it's modified to produce even shorter pulses using Q switching. So this is actually ideal because it combines these 2. So this is a picture just to show what we were discussing in the previous slide, that with continuous, there's continuous flow of energy over time. And then with pulsed, so there's flow, then stops, starts again, stops, starts again. And then Q switch is a combination of these 2. Yeah. And then now, where like the different types of lasers and their uses, as we spoke about the carbon dioxide, which is its laser medium is gas. Then it has an electrical source, and the source of energy is electrical. It has a long wavelength. It's for cutting, coagulation. It can be used for cutting lasers, carbon, and also for skin resurfacing. And then the holmium, or the YAG, it's solid. It has the source of energy is another laser here. This is the wavelength. It's usually used for tissue ablation, lithotripsy, in neurology, for example, for kidney stones, and also for endoscopic sinus surgery. Another form of YAG, it has the source of energy is a flash lamp or another laser, just like this one. This is the wavelength. It's also used for cutting and coagulation, and also GI bleeding, and also tattoo removal, because here you don't want a lot of penetration. It's just the skin. And then there's a diode, which is also a solid. It has an electrical source. It is even a shorter wavelength. It's what we usually use for as laser pointers, hair removal, or barcode scanners. So I'm sure you are familiar with this. And you can see that it has a low wavelength, so it's not, it might not even penetrate because it has a lower wavelength. And then argon, it's gas, as we know. It has an electrical discharge, low or short wavelength. It's used for retinal surgery, AV malformation, thick port wine birthmarks. I don't know what's that. And then I'll stop there, because I just wanted to show that at different wavelengths there's different penetration. So nothing comes with without disadvantages, but we need to measure those disadvantages. So laser unfortunately has some hazards, but we can measure those hazards using what is called MPE, which is maximum permissible exposure levels. So this is basically just a calculation of the highest power density. If you remember, we spoke about power density when we're talking about how the laser interacts with the tissues and all, and the danger, or the energy density. So it's the calculation of the highest power density or energy density allowed for a laser that is considered safe and unlikely to cause damage. So that's how you measure the hazard that can be posed by a laser using this MPE, maximum permissible exposure. This is measured on the skin or on the cornea for a given wavelength or exposure time. So now, when you're using laser, what are these hazards? So these hazards are are broadly divided into airway related or no airway related, non-airway related. So the non-airway related are further also classified into atmospheric contamination, venous embolism, organ or vessel perforation, and then inappropriate heat transfer. So with atmospheric contamination, remember when you're cutting, even with the diathermy, there are plumes that are released, and this could be both hazardous to us as healthcare workers and also to the patient, because it can cause interstitial pneumonia, bronchiolitis, and reduce ciliary function. And then venous air embolism. I try to look for the mechanism of air embolism. Maybe someone will know. I don't know, but air embolism in laser surgery has been described a lot. And then organ or vessel perforation. This is because some people will tend to use laser on vessels that are more than 5 millimeters, thinking that they will coagulate. Unfortunately, they don't. All you will be doing is just to cause a perforation, and that could cause a risk for bleeding. And then inappropriate heat transfer. So if you just put laser on unattended, it can strike anything in the theater and cause, especially if it's an oxygen-rich environment, or you complete the fire trial, then you can cause fires or even explosions. And then now the hazards of laser in terms of airway surgery. Remember, we said we divide them into airway related and non-airway related. So the most feared thing here is airway fire. So with airway fires, how does the airway fire occur? Remember, you'll be having the fuel, you'll be having the ignition source, which is the laser, you'll be having an oxidator, which is oxygen or nitrous oxide. So with a high energy laser, you can perforate or ignite the endotracheal tube. And this has been described to be having an incidence of 0.5 to 1.5%. And then when, unfortunately, PVC material, of which some endotracheal tubes are made of that, when they burn, they produce the toxic material. And they also describe that silicon-based material are harder to ignite. Maybe it could be safer to use those ones if we have. Now, what are the safety measures in terms of laser? This could be a good DA question. So you must have smoke evacuators and high efficiency mask for the workers. You must have laser light under direct vision. You can only use laser light when it's under direct vision. You limit the intensity and the duration. So the lowest minimum, the minimum possible intensity, and then over a short time. You cover the patient's eyes and theater doors. I know we all have a tendency when walking around theater to peep through the windows there. When they're doing laser, you must be careful of this, because it might be that maybe the surgeon has put the laser unattended and it's on and it's facing towards your direction. So it could actually cause a lot of damage. There must be warning signs when a laser is used in theater. There must be goggles for everyone that's inside the theater. There must be moist drapes or throat packs if they're working in the airway. And then there must be a source of water in the theater, like a bucket next to the patient, for example. So this is warning sign for laser. So it's something that maybe we could have whenever they're working with laser. We put this outside the theater. And then in terms of the airway now, what are the safety mechanisms that or precautions that you can do? So if you're ventilating the patient, you ventilate the patient with the minimum effective FiO2 as long as they're maintaining sets. Some describe FiO2s of less than 30%. You avoid nitrous oxide completely. You limit laser intensity and duration like the previous slide. Your endotracheal tube, you can wrap it with the foil if you don't have a laser resistant endotracheal tube. The cuff, instead of filling it with air, you can fill it with saline or methylene blue. It reduces the risk of rupture and also subsequently airway fires. And then now there are also special endotracheal tubes that we have. The different types is a Norton, Bivona, Zomed, Laser Shield, and then this Mallinckrodt. This is what we have. You will see it just now. This is what we have in our theater. And I saw them there. I think we have a lot actually. So this is the Mallinckrodt. So it's a normal shaped endotracheal tube, but it has steel, I'll call them steel strappings covered in steel here. And then it has two cuffs, a proximal and a distal cuff. This is just as a safety mechanism that if, for example, this one ruptures, at least you have a backup and vice versa. So this is called a Mallinckrodt endotracheal tube. This picture was actually taken in theater. So this we have. So you can see it's a normal shaped endotracheal tube with two cuffs, a distal cuff and a proximal cuff. And you can see it has this steel casing surrounding the tube. So this is laser resistant. So this is just still to show the different laser resistant tubes. There are also a red rubber tape that can be used to wrap around a normal endotracheal tube in order to reduce airway fires. They also describe wrapping it with foil, but it's associated with a lot of risk, necrosis, laceration, airway lacerations and all. So no one is really doing that. Let's say now you are unfortunate and you get to experience an airway fire. So what should you be doing? Just remember, fire is a triad. All you are trying to do is to break the triad. You want to extinguish the fire and also break the triad so that the fire doesn't continue. So you remove the source of fire. If you're using laser, obviously you switch off laser, you remove it, you disconnect the patient from the circuit and from the machine, and then you extubate them. You extinguish the fire. If there's still fire, you extinguish with water, and then you bag mass ventilate the patient with 100% oxygen. To maintain anesthesia, you can give IV anesthetic agents, and then you can do a direct laryngoscope or rigid bronchoscope to assess for damage and debris. And then after that, you can re-intubate the patient, and then you can do a lavage to try and get rid of the debris if it's there, the smaller one, the smaller particles. And then if there's severe damage, that patient may need a tracheostomy. And then you also have to assess the oropharynx and the face if they are not damaged. And then you can do a chest x-ray to check. Remember, when there's fire, if you remember from my presentation, if there's fire, there could be incomplete byproducts of fire. There could be complete byproducts of fire. The incomplete ones, they tend to accumulate like carbon monoxide. The others, especially when PVC is burning. So we might have chemical pneumonitis. Role for steroids, it's debatable. Also, role for antibiotics, if you don't have evidence of infection, there's no need for you to give antibiotics. So yes, that's all from my side. Apologies for taking long. Yeah, I'll open for questions, comments, additions.